chance now. So while we're waiting, if you look under your seats, there's 2 agendas somewhere in this room. So check under your seats and let us know.
So I just use
If you don't have anything on your seat, you should check the seat next to you or behind you.
this one to go forward.
Put all that into chair. On the empty seats.
Okay.
Anybody else? Should be 2. What do they look like? Well, they're a Stanford thing. I'll tell you that.
2. One more.
There you go.
Okay, so are you ready?
Yeah.
So Tracy's ready. All right. Just go back.
So I'd like to thank Dr. Mila for inviting me here today, and congratulations to everybody in the room that made it through the rain. I keep waking up lately and thinking I'm back in England, so I don't know what's happening, but I think we need it, so I won't complain. I'm going to talk to you today about infection control in CF patients and bugs and what we can do to protect patients from some of these bugs and infection control measures both in the hospital and in the community. So measures to shield from infections, the screening, which is really important, hand hygiene, which is probably the number one thing we can do to prevent the transmission of infection, isolation precautions, which I'll talk about and why we do that in hospital, respiratory etiquette, and then the disinfection and sterilization of the environment. And remember, the prevention is key. That's what we're trying to do. So the most effective action we can take is really hand washing. Alcohol, gel and foam are actually good. They're the best, and the reason for that is that they're very available. In the old days when we had to go and find a sink and use soap, compliance with hand hygiene was not as good. We have improved that in part because of gel and foam. However, hand hygiene must be used if the hands are visibly dirty or if a patient has C. diff or norovirus. That's 2 GI illnesses that have diarrhea, and in those cases the gel or the foam does not work. And the friction of hands is really the most important thing. So you need 15 seconds of rubbing the hands together, at least 15 seconds to remove the bacteria. Artificial nails have actually been known to cause Pseudomonas aeruginosa outbreak in hospitals before, in ICUs. So the CDC came forward and recommended that no artificial nails be allowed in healthcare facilities. So that is a policy at Packard, and you'll find that's the same in other hospitals. So the 5 moments of hand hygiene, this is actually a World Health Organization way of getting the message to everywhere. Whether you're in America or whether you're in Africa, wherever you are in the world, these are the reasons and the times that you need to perform hand hygiene. So this is mainly used in the hospital to train healthcare workers, but I think it's good for families and patients to understand that, so you can make sure we're doing what we should be doing, and also so you're aware of that, in your own homes. The number 1, of course, is before patient contact. Number 2 would be before an aseptic technique or a task. So if a nurse, for example, comes in, they've performed hand hygiene, and now they're going to put in an IV or something like that, that would be a second occasion where they need to perform hand hygiene. After body fluid exposure, so for example, if they're changing a diaper, that would be a reason, and obviously at that time you would wear gloves. After patient contact, and then after patient's contact surroundings. So the nurse may have touched the patient and be going to the door, and then performed hand hygiene and go back and touch the table or touch the pump, etc. That would be another opportunity to perform hand hygiene, because what we're finding is not only the patient may be colonized with organisms organisms, but the whole surrounding area. So we don't want to take that patient's organisms back into the healthcare environment out on the units everywhere. So I thought this was interesting. Anybody that's been in the hospital, you may have seen this because we have this posted in a lot of places. But it sounds funny, how do you actually perform hand hygiene? How do you wash your hands? And we realized that it's not as obvious as you think. So I wanted to include this. So you can see we do this first, and then this, and then this, and this. I'm doing it quickly. This should be 15 seconds. And then this, and then this. And if you think about it, from doing that, you should have got every surface. If you're doing this, like kind of the old way we used to do it, you've missed in between, you've missed there, you've probably missed the thumbs. So this is really good education because it is really important to do hand hygiene, and we need to be able to get every surface of our hands covered. And that would be the same if you were using gel or if you were actually washing your hands. So screening is also very important. This is another thing we can do to prevent infections coming into the hospital and making your children or yourself sick. We have a security guard at every entrance at Packard, and we have trained them to ask questions, and this really is for the safety of our patients. So we ask questions to see if they have an upper respiratory infection. Do you have a fever? Do you have a runny nose? Do you have a cough, a cold, etc.? And then we want to know if they have any GI infections, of course, that could be passed on as well. So we're asking if they have any vomiting or diarrhea. If they have any exposure risk, such as they've been exposed to somebody with chickenpox, measles, or TB, and then if they have a rash or a fever. And if the answer to those are yes, there'll be more questions, and we advise them not to visit. Now, there are times where someone has to visit. For example, it's the only guardian, they want to take their child to an important clinic visit, and in that case we would provide mask and tissues, and we would do some teaching about how to dispose of those and respiratory etiquette. But most of the time we do not want sick people in the hospital, obviously, to protect our patients. That's our number one job. It's also important for you to be your child's advocate and to screen families and relatives and friends that may be coming to visit. It's very difficult if you have families coming from another state and then they're suddenly sick, but this is really important, and this is something that you can do. And of course, screen yourself. You have to be honest. Even if you really want to see your child, if you're sick, you just should not do that. We don't want to get people sicker. So respiratory etiquette, I spoke about this. This is the stop signs we have at Packard at the doors saying that sick visitors can't come. And then there's teaching involved. So we're teaching patients and visitors too how to cover their cough and their mouth, sneeze into their sleeve, etc. Just give me 1 second. So I know that a lot of CF patients will use respiratory therapy equipment. And this is something I remember under disinfection and sterilization. It's really important to make sure that these things are disinfected and dry. So you should use soap and water to remove all visible secretions, and then disinfect any reusable items. Obviously, if it's a single use, you throw it away, but many of these things aren't. So at home, you can boil the water for 5 minutes, immerse in diluted bleach, use a standard dishwasher if it's hot enough, or a microwave, depending on what you're using. And then make sure that all equipment is thoroughly dry. That's really important. Sharing equipment at home between siblings should be discouraged, because obviously there can be cross-contamination and transmission of germs that way. And then sterile water is advised instead of tap water, because tap water can potentially be contaminated with pathogenic organisms such as Pseudomonas. Standard precautions. This is a term, again, that we use in hospital that applies to all patients regardless of their suspected or potential infection status. So we don't know, but people may be infected, and so we want to provide a barrier between that person and the next patient that we're going to. So a big part of that, for example, would be hand hygiene that I've talked about. And then you see healthcare workers wearing gloves when touching any body secretions. Gloves are not a substitute for hand hygiene, so we teach everybody in the hospital, before you put your gloves on and when you take your gloves off, it's still really important to do hand hygiene. The use of a mask, and that would include, or could include, eye protection and a face shield. This is to protect the mucous membranes of the eyes, nose and mouth during procedures where there may be aerosolization, so of blood or body fluids and secretions. So respiratory etiquette is considered part of standard precaution. That's really the nurses or the healthcare workers' judgment, dependent on what action they're going to be performing. So then, as your child's in hospital, you will see on the door contact and droplets. So I'm just going to explain to you what that means. Contact precautions is really the use of gown and gloves, and this is used when we have patients who are either known or highly suspected to be infected or colonized with epidemiologically important microorganisms that can be transmitted by direct contact. So because we know CF patients are often infected or colonized, meaning that you have the organism there but it's not actually causing infection at this time, we want to place on contact precautions both to protect that patient and to protect the next patient we may be going to. So either with the patient or the indirect touching with the environmental surfaces or patient care items in the patient's environment. So both the patient and, as I explained before, the environment around the patient. Droplet precautions. I love this little picture up there. It's quite scary how far that's coming out. So droplet precautions would be a mask. Someone sneezes in your face, you certainly want to protect that, although hopefully they've got the elbow. They've learnt that part of it. So a mask, and then face shield and goggles, again, if you feel is appropriate. So patients known or suspected to be infected with microorganisms transmitted by droplets of over 5 microns. Generated by the patient during coughing, sneezing, talking, or cough-producing procedures. And these are fairly large droplets that do require close contact. So if I was coughing here, unfortunately you may be at risk, but everybody else would probably be okay. So they're not suspended in the air. They basically are travel short distances. Now, you may be aware there is new CF guidelines coming out kind of any day now. And with the new CF guidelines, the advice is that the distance between the patient and another patient should be, or a caregiver should be, 6 foot. And we can talk a little bit more about that lately. But as far as I know, they're not out yet, but it should be very soon. So we're going to figure out how we can work with that in the hospital to be successful. Airborne precautions. This is an N95 mask, so it's a tighter fitting mask that has more protection, and again face shields or goggles if appropriate. So who do we place on airborne precautions? This is for patients known or suspected to be infected with airborne transmissible pathogenic diseases, and an example of that, for example, would be TB or chickenpox or measles are the 3 most common ones. Because they're very small, they remain suspended in the air. So it's not just like with the droplet, when you cough, it comes out and then it drops. This will actually kind of hang in the air. And so related to that, we have patients in negative pressure rooms. Now for CF patients, this is not something normally that they need, but because they may get mycobacterium different to TB, but related to that, when we're doing a rule out, there may be a time when they're in this room until we can rule out that they don't have TB as well. So that's why I put this here. It's not something that you would see that often, but it may occur. Bugs commonly seen in CF patients. For bacteria, the Pseudomonas aeruginosa, Staph aureus, Staphylococcus aureus, that's MSSA, which is sensitive, and then MRSA, which is the resistant type. Stenotrophomonas multifilia, and Burkholderia cepacia complex. And then viruses, influenza and RSV are probably the 2 more of concern, but there are other viruses that we test for. And again, for fungus, there's several different funguses, but the one that we work very hard in hospitals, at least, to prevent is Aspergillus. Pseudomonas aeruginosa is probably the most important and prevalent pathogen in CF patients. The source is usually unknown, but it can be environmental. It can be from another patient. It can be from contaminated respiratory equipment or other objects in the environment. Aggressive antimicrobial treatment at the first diagnosis may delay chronic infection. And by age 18, 80% of patients are infected with Pseudomonas. It's suspended in the sputum of a CF patient and can survive up to 8 days on dry surfaces. So this comes back to the importance of environmental cleaning and disinfectant. It can also be found in water, hot tubs, swimming pools, or potentially dental equipment. So then we have MSSA and MRSA. These are actually very common organisms that commonly colonize the skin and the anterior nares of both people with CF and just the general population. Originally, MRSA was found more in healthcare settings, but it's now becoming more prevalent in the community, so we really have to be careful wherever we are, basically. MRSA is different around the country. On the East Coast, they have more than they do on the West Coast, and in general, it's more common in adults than in children. But certainly for CF children, because they're more at risk, it's not uncommon for CF children to have this. It can be transmitted person to person by droplet, that would be coughing, by skin-to-skin contact, or again with contaminated environmental surfaces or equipment. We have a law, in California called SB 1058, which is also called Niles Law, which mandates that patients that meet certain criteria that are admitted to an acute healthcare facility need to be screened for MRSA. So again, this probably happens to your patients when they come into the hospital, and you may wonder, why do we do this? We do it because it's a law, and what we do is a swab from the nares that gets sent to the lab to see if a patient has MRSA. If they do, the physician tells the patient and does teaching, and really it's meant to be an awareness to the whole community. As you come into hospital, that's interaction with a healthcare facility and healthcare workers to teach the community about MRSA and various infection control practices both in the community and in the hospital to stop the spread. So some of the patients meeting criteria would be all patients admitted to an ICU, or patients if they've been transferred or they've been in a hospital or an acute care facility within the last 30 days. So if you happen to come in to the hospital, get admitted, go home for 4 days and come back, you might think, well, why are we doing this? We just did it 4 days ago. So there's your answer, we have to. Viruses. Patients with upper respiratory symptoms, when they get admitted or seen in the clinic, will typically have a nasal swab sent to see if they have a virus. We test for influenza, parainfluenza, RSV, metapneumovirus, rhinovirus, and adenovirus. Now, CF patients are not more likely to get viruses compared to the general population. We're in virus season now, so we're all somewhat at risk. But if they do get viruses, they tend to get sicker. So it is important to try and keep away from sick patients and to protect those with CF. The CDC recommends an influenza vaccine annually for patients with CF who are more than 6 months, and also to their household contacts. Viruses can cause worsening pulmonary function, and influenza is associated with this more so than other viruses. So Tamiflu, which is a treatment for influenza, can be given both as a treatment or if a patient is needs prophylaxis because they've been exposed to somebody with influenza. And that's just a little reminder, get your flu shot, it's still not too late. Fungi. Aspergillus fumigatus is probably the most common fungi, at least found in the environment. Now, the fungal spores become aerosolized, and the risk is as they become aerosolized, they're breathed in, potentially by all of us, but with a good immune system, that's not a problem. With CF patients, where the immune system isn't as good, that can cause infection. And the places that we get this are construction, gardening or lawn cutting, building. If there's water leaks, for example, moldy showers, that mold that you see can be aspergillus, or dusty environments. Now, it's not transmitted patient to patient. There's also allergic bronchopulmonary aspergillosis, which is an allergic reaction to aspergillus. Several people are allergic to mold, and that potentially has to be treated with steroids and antifungal medicines. Constructions in hospitals, you may have been taught to keep your child or your loved one with CF away from construction sites. One of the reasons being is that there is aspergillus in the soil and in the building and the dusting as we're doing that. And then you come to Packard and you see all this construction, and that might make you nervous. So I wanted to explain all the very strict rules we have around construction to stop people getting sick, because we recognize it's a risk, and so we're very careful to eliminate that risk as much as possible. So any construction projects at Packard or at Stanford, any of the hospitals really, we have a pre-construction meeting. This is infection control, the project managers and the people that are actually going to be doing the construction work. We work through the site, and then we have an action plan of what precautions they need to take, and this typically can be containment, meaning that we're actually blocking off the construction site. We build walls so that they're behind a wall. And that behind that we can have negative pressure so that the air basically can't escape out into the general hospital area. We have the workers wear bunny suits, and we have sticky walk-off mats. Also, when they come from the dirty area back into the hospital, any potential aspergillus or any dust or dirt is kept within the construction area. So all construction projects have to be approved by infection prevention and control. We sign off before the work is started, so before they actually start the work, we go down and we make sure that the plan we agreed to is actually in place, that the containment is up, that there's no holes, that it's totally sealed, that we know exactly what they're doing, how are they going to remove any dust or any dirty things from that construction area out of the hospital without putting patients at risk. So there's a lot of time and effort looked at this to make sure that we have prevented any problems. Again, when they finish their work, we have to check that everything is okay before the containment is taken down. And every day we go and look at this. There's daily inspections. They have a check sheet that we have to make sure that they've done everything correctly. And then oftentimes, depending on where the construction is, we do air samples, because that will tell us if there's a high level of construction in the air. If we went where the big hole is next to Packard and there's all the mud and construction, there would be a high level of aspergillus, but you should not have that in hospitals. So what we do is we take air samples, we grow them in the lab, and we can see if we grow aspergillus. So one colony, 2 colonies is not of a concern, but it shouldn't be a high level, and so far we haven't had a problem with that. Environmental cleaning. It's important to use manufacturers' recommendations for cleaning and disinfecting patient care equipment. In hospital, we try and have as much as possible dedicated equipment for each patient. Some things you cannot do that, so it's important to disinfect between patients. Patient rooms and bathrooms, we are cleaned daily, and as I say, a single room for patients whenever possible. You probably see in the hospital we use the grey top Sunny wipes. These are standard cleaning wipes for equipment, and that's what's used. The nurses or any healthcare worker really can use these. They need to wear gloves to protect themselves, and the surface has to remain wet for 3 minutes. So I'm just letting you know that, so you think, well, how do they clean all these things that they keep bringing in and out? So that's probably the main way that we do that. And there's a picture. Hospital or clinic policies. CF patients are isolated in hospital and as much as possible in the clinic. We have them on contact droplet precautions, which is what I was speaking about earlier. Unfortunately, they're not allowed in the playroom, and neither is a sibling for our patients in isolation. If they do go outside the room, they need to wear a mask. And as I say, they've changed the CF rules, so it's now there'll be 6-foot protection needed between the patient who has CF and somebody else. And then the door of the room should be closed. And of course, this is very isolating. You're stuck in hospital, and now you have people coming in wearing a mask, the door's closed. So we're really trying to work to help with that and provide emotional support using child life, using toys, games, physical therapy, and as much contact with family, relatives, and the outside world using all the latest tech toys that we have available to us. In the community, at home, patients who have CF should not be sharing with their siblings things that touch the mucous membrane. So, for example, toothbrushes, cups, RT equipment. The home should be kept as dust-free as possible. It doesn't need to be perfect, but if there's a big build-up of dust, aspergillus can actually be found in dust. So it's important to at least keep it clean. Keep areas dry with no standing water, which again can harbour Pseudomonas in showers and sinks. Pets are okay. Swimming pools with chloride are okay, but avoid hot tubs because they tend to have a higher level of Pseudomonas in there, so it's a little bit more of a risk. Avoid digging in the dirt, and then a balanced approach to reduce risk, but still let them have fun. Here are some references. The CDC and the CF Foundation are probably the best places to go for that. And then I've cited some infection control guidelines that we have for healthy, happier lives. Thank you. Questions?
I just have one question. Do you recommend that CF patients actually not drink tap water then and rather drink sterile water due to bacteria?
No, they can drink tap water, correct?
So was it, when you were referencing the bacteria in tap water, was that just with respect to sterilization?
Yes, I'm sorry. I was talking more about if you're doing a respiratory therapy treatment, something like that you're mixing, then you should use sterile water, not tap water.
Oh, okay. Thank you.
Or boiled water, yeah.
Clorox wipes and those kinds of things.
Yes, Clorox wipes are good. They will be able to disinfect. And again, you have to keep the area moist. So you should use more than probably most people do and take longer to actually wipe somewhere. If you do a quick wipe, it's not as effective.
And just to clarify for the sterile water, if you're not boiling it, do you mean like purified, distilled, spring? What do you mean for sterile water? I've been using like spring water to pour in, like, let's say the microwave bottle sterilizer before I put it in the microwave for like the neb equipment. But let's say for like the chamber, the aero chamber for the the inhalers and things like that, can you specify a little further for the sterile water?
What do you advise on that?
If it's for rinsing?
Yeah.
Is that your question?
Like cleaning, let's say, for example, the aero chamber, when I'm cleaning it after, like she
Yeah.
does her inhalers.
Yeah. You could truly use all the way down to tap water.
Okay.
The important thing is to let it dry completely.
Okay.
Because it's the dryness what kills the germs. Just
Okay.
wiping them, because you could rinse with double distilled water, but if you let it sit moist and use it that way, you can have some germs in there.
Okay, thank you.
So we have one more question from Ustream. Is shower head cleaning recommended, and if so, how?
Yes, I would. I mean, again, it's something that you shouldn't over worry about, but it is good to keep the shower heads clean. I think, if you unscrew them and clean, because there is build up there, that was all I would recommend. I don't know how. Just really keeping them clean so it's not a lot of water there. But it's not something that you should worry about or do frequently.
Last question.
My daughter did a science fair experiment with auger and just going around the house and swabbing things. Is that something that if people are worried about shower heads? I mean, is that something that you can actually find? Just useful information from swapping things around the house, or no?
No, we really wouldn't advise that. I would just try and, go about your life as you want to, and just keep in mind it's best to keep things, clean and dust-free, but you don't want to over-worry and Okay.
Thank you, Tracy. That was great. And, we'll have plenty of opportunity during the breaks and lunch hour to keep the discussion going. Briefly before break, I would like to invite Dvorak to give us an update on the support groups. It's a very important component of the many things that we provide for you guys.
Thank you.
Hi, everybody. Good morning. I don't have any slides. This is the only one. So I'm just going to talk about my programs. So my name is Dvorak. I am the adult cystic fibrosis social worker. And I just want to talk about 3 programs that I've been involved in for the past few years since I came to the program. And with this CF becoming such an isolated disease community, I feel that we have to get more and more creative every year in how to keep patients connected, share information, and support one another. So all 3 of these programs have a pretty strong technology component. The first program I want to talk about is my adult cystic fibrosis support group. The group's been going on for over 3 years now, and it's going really strong. We meet once a month on the first Friday of every month from 11:30 to 1. And as of last year, the group is WebEx participation only or teleconference for people with cystic fibrosis. And I do allow one person with CF in the room, and then if there's a caregiver, volunteer, someone who wants to learn about the group, I can have those people in the group. And so every month I send out an email to a large distribution of patients and families, and the email includes a description for the group. It also has a link to the WebEx and a phone number and a passcode to call in. So the group is pretty secure in terms of the WebEx. It's got extra layer of encryption and privacy that's provided by Cisco. Every month we pick a topic for the group that's related to living with cystic fibrosis. We've covered so many topics in the last 3 years, ranging from communicating with others about your CF, maintaining work-life balance, relaxation techniques, et cetera, et cetera. So we have about 6 to 8, I would say, attendees per group. I'd love to grow that number. I think the more people that are in the group, the better. So if you're interested in participating in the group, I want to encourage you to try it out. You can get the information about the WebEx and the link and all of that through our CF Center website, as well as our CF Center Facebook group. And I also send out the monthly emails. So if you want to get on my email distribution list, I have a sign-up sheet outside on the registration table. Just put your name and email and then check mark whether you want to be added to my support group list or my Facebook list. So that brings me to my next project. In partnership with the Adult Advisory Board, we started a Facebook group in October. It's for CF adults and their loved ones over the age of 18. And the group was specifically designed and created by the social media staff at Stanford Hospital with a mindfulness about following pretty strict social media guidelines. I'm a silent moderator in the group, so all the posts are read by me just to ensure that we're following the policies. And so far, the group has 68 participants and counting. So I want to get that number up too. It's a great group. We love it. It's, in terms of privacy settings, the group is a secret group, which means that only members who are invited into the group can see the posts, see the name of the group, see the tags, see the description, and all of that. So if you're a person with CF who's really private about your disease and you're in this group, no one in your regular group of Facebook friends is going to see that you have any affiliation with this group. If others nationally want to search for this group on Facebook, they're not going to find it because it's the most secure form of privacy. The posts are very interesting. We get about 3 posts a day, I would say, and numerous comments on the posts. They range anywhere from really interesting and up-to-date research and education in cystic fibrosis, humorous banter about living with CF, as well as just, kind of support one another. I had a patient who described the group as part support group, part education, part information sharing, and part solidarity. And before this group, she didn't even see the point of Facebook. She never used it. And now it's kind of transformed the way she uses the technology. So if you're interested in joining, I can send you an invite from the group by email. So I'll need your email address. Please sign up at the registration desk outside. And then my final project I want to talk about is the peer-to-peer program. This is an adult peer mentoring program at Stanford. We started it in 2012, and this is sort of the adult version of the parent mentoring program at Packard. And so far, we have 6 adult CF mentors trained, and they've been mentoring various people. We focus the program on patients who are going through a difficult transition with their health care, be it transitioning from pediatrics to adults, transitioning from having CF to sort of moving into lung transplant, or perhaps a newly diagnosed adult, which we see more and more of every year. And it's great for CF because we can do all of the mentor trainings through WebEx, and then all of the contact between the mentors is recommended to be virtual only for obvious reasons. And this year, we will be expanding the program into lung transplant. And right now, CF isn't the only program in this mentoring. We have liver transplant, pulmonary hypertension, heart transplant, and now lung transplant. But CF was one of the 2 to pilot the program and make it successful, make it what it is now. So, does anyone have any questions about any of those 3 programs? Okay, so if you're interested, just go ahead and sign up outside. Thanks.
We're going to take a 10-minute break. Please don't drift too far away. We're going to try to start right on time to catch up a little bit with the time. Thank you.